slide on a while ago. I don't know if I covered all that or not. So you can call me back out and I'll try to fill in the blanks. Start off with a little story about three guys. You all like basketball around here? Yeah. So three guys playing basketball, and they're playing horse, and then all of a sudden, poof, they're not on the basketball court anymore, and they realize they're standing in a desert, and they all wonder what's going on, and in front of them, a genie appears, and he goes, "You guys have to live in this desert for 3 days, and you have to survive. But you get to pick one thing to keep with you," and then he disappears. And then all of a sudden, bam, all of them are holding something they thought of, right? And they had a split second to make a decision. The guy on the end looks over and looks at his, and he looks over at the guy on the other end, and he goes, "What do you got over there?" And the guy on that end goes, "Well, I got a jug of water." He goes, "Oh, all right." And he goes, "Why?" And he says, "Well, if I get thirsty, I can drink it in the desert." I said, "All right." And he said, "Well, what do you got over there?" And he goes, "Well, I've got a sack of food. If I get hungry, I can eat it." "All right, that makes sense. We're in the desert. We've got to survive." And they look at the guy in the middle, and he's doing this. And they said, "What do you have?" And he said, "Well, I've got a car door." And they said, why do you have a car door?" And he said, "Well, if I get hot, I can roll the window down." It was kind of where he was going with that. So all those guys had a choice that they could make to make it through a certain situation. They could pick a tool. They could pick something to do. In healthcare, we're getting ready to go. Well, we're not getting ready to. We're in the mode of transitioning. We have to make it through this, and we've got choices on how we do stuff, choices on how we can integrate. So we've got to pick tools. So we're going to talk about some of the tools that we've got that you all also have as far as making that transition into value-based medicine, right? So hopefully we're not going to be the guy with the car door rolling down our window. That's probably not the most effective tool he could have chosen. What I'm going to do, I'm not going to go through PowerPoint stuff. I'm going to actually go into systems, and so if it's slow, if it's fast, whatever, it's going to be what it is. But I'll go into that, and we're really going to talk about how you all use some of this technology, what the technology is, how it empowers you at the point of care to care for those patients and really prioritize stuff. Before we get into that, let me figure out how to run this thing. Okay. We've kind of got some mission stuff to really figure out how to let providers be providers. And in the end, we want technology to do all the work for you that it can. Rather than hinder you, we want it to enable you. So we'll start with this. Hopefully it won't be too loud. So that right there is really all about taking back some of your profession, getting you to, how many people feel like they click and they went to medical school and a computer is who you really treat most of the day? I think some people have that. Within one partner and HMG, really the whole thing, our goal was to make it to where that's not the case anymore. You get to spend quality time with the patients and build those relationships and have the system working around that relationship to make it all function and work. Computers right now, some of the stuff I'm going to show you, you're going to feel like I'm saying the opposite thing because there's still clicks we have to do. There's certain things we have to record. But the goal in the future is get it to where all that stuff happens. The only way we know how to get there is to take the steps we're taking today to figure out how we make the computer solve the problem. Our goal, that's really where we want to go. We think that physicians can treat patients, and let's just give them the information at the point of care so they can do that. What I'm going to do here is I'm going to log into two different systems. One is I'm going to show you what the EHR agent, have you all ever heard of the EHR agent? Wow. Yes, there we go. So how many people want to see information on their patient and understand that if it came from somewhere else or have their patients stratified or know what diagnosis codes you might be missing that somebody else has treated that patient? Does that sound valuable when you're treating those real chronic patients? Well, how many of you want to log into a separate place to go check all that? I don't see any hands in the room to do that. So before I get into these screens about how some of the information, we have been connecting Nebraska together for 3 years, something like that, and onboarding clinics. Some of you all have been through that process. I know it's not perfect, but hopefully we continue to get better. And now we're to the point where we've had enough information. We want to make sure give you actionable information at the point of care, but we don't want to give you a separate portal to log into. So I'm going to go here real quick, and I'm going to log in just to show you this is not vaporware and it really does exist. Then I'm going to kick back over to another view and run most of the presentation from the website, just because it's a little smoother that way. So right now I'm logging in to some servers in Duffield, Virginia real quick to show you this. And if it doesn't work, we'll just go into the other thing. But you're going to see me log into the EMR. You're going to see me bring up a test patient, and you're going to see this little thing in the corner start to change. And this right here is called the agent. So Holston Medical Group runs TouchWorks. Some of you all run different EMRs. Who likes long passwords? Because believe me, IT people love them too. It's our favorite thing. Actually, policy drives us nuts as well. We've got a few attorneys in the room, so can't say too much about that. All right, so what we have right here, just to show you all this works, is this thing floating that I'm moving around. That's called the EHR agent. So that's, you've sent information to the HIE, other people send information to the HIE, the Health Information Exchange. Hospitals can send information to the Health Information Exchange as well. And that gives you an idea what happens with that patient where in the community. We have this thing called Clinical View Agent, which I click on that. That's actually all the clinical data on the patient that we've gotten. So if you want to go and look at diagnosis codes, procedure codes, office notes, discharge summaries, any of that stuff, it actually shows up in that view. And see, there it comes down. And it's organized by encounters and all ambulatory emergency room, inpatient, all those type of things. That right there, if you have just that, we thought that was good enough, right? And I remember when I first started this, I said, if I get 2 clinics within 20 miles of each other, sharing this information, I can retire, is what I thought. And I did it. It's called my so what story. I did all that, and the doctor said, so what? You know, when we got all that done. And that's a big deal in the nation. That's called interoperability, all right? That's what Epic and Cerner and all those are really proud that they can kind of do now. They can send CCDs back and forth. They don't even have it organized like this, you know. If I go down into one of these, you know, you'd see an ambulatory visit. Well, that happened at the hospital with their outpatient stuff. A gastroenterologist was in here somewhere. You know, all that within your EMR, you didn't log in anywhere else, you didn't search anywhere else, you did it in your EMR, and it knew what you did, right? So Epic and them are really proud of that stuff. We thought that was good enough. The doctors quickly told us, no, that's not good enough. You need to do more. So then we went in and we connected those hospitals, right? You all have patients show up in the hospital occasionally, and you might not know about it for a couple weeks later, months maybe. And we connected those guys in, and we thought, yes, we've done it. This is fantastic. And the doctors actually came back and said, that's pretty good. We're okay with that. Now when the patient's in our room, you know, they're sitting in the exam room, we go in, we click this, we say, oh, we're in the hospital 2 weeks ago, what's going on? And they don't have to call to get faxes and all that stuff. They like that. So we thought, all right, we're doing good. The administrators said, so what? They said, we're not going to go look at every patient's chart. We're not going to go chase all this stuff. We need to know that patient was discharged from the hospital so we can do a what, Samantha?
Transition of care.
Right, transition of care. We're not going to go look at their chart every day. There's no way we can do that. We have 5,000 patients we care about. So we said, all right, what are we going to do? So that's here. We failed, but we've stepped forward every time. So then we started building these little things right here. We have a thing called patient insights, and we have a thing called provider insights, and that's what we're going to spend most of our time on. But as you can see, they are accessible from within the workflow. That was key to do, is because doctors have to be able to interact and know about this stuff, and they still have to be efficient in their day-to-day practice. Administrators get the benefit, nurses get the benefit, and this is for your entire patient population. This is not around your Medicare population. It's anybody, we all the data is information for us, so we do it on any patient. So you can see if you click on one of these, it actually brings up what's called insights, and I'll get into more detail on this. But this right here is a provider's treating a patient at the point of care. They come in your office, and this is all about the provider and nurse and patient workflow. We'll get into administrators here in a minute. Doctor clicks on that, and it's got that little 3 up there. That means there's 3 things that are important on this patient right now. That could be a 7, that could be a 10, so it's kind of training your brain to think, oh, well, is there something I need to look at? The majority of your patients will have nothing up there because they're 35-year-old male or they're young, healthy. I mean, it's the majority of the population doesn't have, you don't need this tool for them because they're just coming to do their checkup routine or whatever, or to get their antibiotics for their sinus infection or something, they want to go home, right? It's the 5% of the patients that you really care about this box on, right? Those ones that are really chronically complex patients that are consuming the majority of the resources, and you need to do stuff. Does anybody know which patients of yours right now are those patients? Some of you do, yeah. And do your nurses know that, or do the administrators, or do that? It's about making sure everybody's on the same page with those things. So one click here, I get to see Heather One Partner, and I get some demographic information, but I see at the strat level, I think one of these points. Yeah. Strat level 3, 10 categories. She's a level 3 patient, 10 chronic conditions, right? So we saw earlier that 4 or more starts driving tremendous amounts of spend. We're from Tennessee. We're really not very smart, even though some people in Middle Tennessee think they're really smart, but we're on the eastern side. We just said, 0 to 1 chronic conditions, you're probably a healthy person. There's not much going on with you. 2 to 5, yeah, there's something going on. Your body's starting to fight itself. 6 or more, it's out of control. The government went on 4 or more, but 6 or more, your body's fighting itself all the time. It's not usually going to get better. So that's our stratification algorithm. You all have access to this. If you've sent your data into One Partner, this has been done on your patient population. We can show you your level 3 patients. Those are the sickest of the sick. Those are the ones you do not want to show up into the hospital, right? You're trying to keep them out of the hospital. That's 40% delta on the spend right there, just on the procedures done, not to mention the fact that a hospital visit, emergency room's $10,000, by the time you go into the hospital, it could be $20,000, $30,000. And in the new model of care, that's coming out of your pocket because you're at risk for those. The government's saying, if you all keep them out of the hospital, we'll give you the money, right? We'll share that with you. So if you start thinking every time they go to the hospital, you're just handing that hospital administrator his paycheck is what's really happening. ACP org, right? That's who they're attributed to. So CMS has an algorithm to do this. They say this patient belongs to you and this patient belongs to you, and that's based off of how you're credentialed as a physician and how many times that patient sees you, right? We have an algorithm too, because CMS doesn't give us data on commercial payments or patients and all that stuff, so we have to calculate that, but we know how you're credentialed based off how you're credentialed CMS. So we calculate that. We can override that to what your payer says, so it'll match. And then we say, oh, ACP provider, that's the doctor you're seeing the most, right? So this is what's really eye-opening to people. Screen res is pretty small here, but all right. Click on that button, and this is the doctor at the point of care doing this, right? And he says, oh, my name's in there or my name's not in there, right? If his name's in there or her name, that means the patient's attributed to them. If it is not, that means the patient's going somewhere else for the majority of their care, right? Either another internal medicine primary care doc, or they're going to a specialist that they're seeing a whole bunch to get that attribution. This is eye-opening to doctors because your patient is going elsewhere. They are not just staying with you. They are normally seeing other people, and I guarantee you within SERPA, I can show you some of these as well because they're going between clinics. Maybe not as heavy here, but if once get a hospital in there, you'll start to see a lot of this going on. But that's the care team treating the patient, right? And if you've got a physician that's doing the total knee replacement for $50,000, they're going to show up in here, and you probably want them to go to a cheaper one because in the new world of value-based medicine, quality's supposed to be all the same, right? Everybody can get 100% on quality, it seems these days. Every ACO usually does really, really well. So we've seen quality is not going to be that different between all the people providing, so it's really going to be the cost is the way it's going to run. But this is a very eye-opening picture to people, and you can see we got family practice and internal medicine and oncology and all these things. And then over here, the number of visits they've had, 40, 9 with this provider, 3 with this provider. That's an important thing to understand on your patient population.
Medical providers, or does it include physical therapy, chiropractic?
If they're connected to the system, we've got it. So, and we're going to bring that in from claims as well, but we don't right now. But right now, if they're connected into one partner, it's anybody, right? So it'll be, if you bring in a physical therapist group across town, then it's going to show up there as well.
Is it just Nebraska providers?
That's a good question. No. Anybody connected to one partner across the entire country. Believe it or not, you had a family of 4 leave Nebraska, and they moved to a place called Elizabeth in Tennessee. And they went into they switched doctors to a physician practice called Medical Care LLC that is in this HIE. And they have all the information from your practice down there when that family moved. And you might know them, you might not, but I don't know the names, so I'm not going to resolve any of that. But yes, anybody connected in the state. We are in 8 states. So if your patient happens to come to Tennessee or happens to go into Vermont or North Carolina or Virginia or Arizona, and there's a place in California, you know, if they show up there, we'll get them. We are working with the big epics and all those on how we can pull information, but those interfaces aren't as clean as when we directly connect because it gets kind of watered down. Yeah.
To your overall mission statement of put the patient first, what steps are you taking to incorporate other data outside of one partner into the system? So like the Nebraska has statewide.
Their HIE, NEHI, yes. So we're happy to connect. And I offered with NEHI, I said, listen, we'll connect. We'll do bidirectional connection. We'll send you all the data we have on your patients. You can send us all the data that you have on the patients we match on. We'll totally pay for our entire side of the interface. We'll do all that as long as you'll do the same thing on your side. And as we went through it, basically it came out to no, they're not really willing to do that. You know, and there was, you know, attorneys and all that. My favorite people, attorneys, go through that whole process. And I said, we'll cover all our legal fees if you'll cover all. I mean, we're willing to do it one for one. And we kind of got some pushback from that. So we've not connected yet. We're still willing to do that. You know, willing to connect with any of those. And we want it to be fair, open, bi-directional exchange of information is what we're looking for. Yes?
Is that the same with if you one-to-one for if we try to get our hospital or
Yeah. So with McCook Hospital, we came in and interacting and negotiating. Anybody work for a hospital here? Okay, so I can talk freely about hospitals. We have to have hospitals in the United States. We cannot do without them. No, I'm a big fan. That they serve their purpose for sure. We offered to connect McCook and we had a grant, and we wanted it done by December 1st is when we wanted it done by. And the attorney showed up in the conversation, and basically McCook said, "There's no way we can get this done." And I think it was like they had 2 months to review the contracts and the data sharing arrangements to say yes, we could agree to it and do the onboarding by that point. But we are, you know, an emergent itself sees the value in these connections. So we try to make the barrier to entry for a hospital as low as possible. So in several scenarios, we go in and say, we're not going to charge you a thing to connect, right? You can connect, but they have to do their side of the interface. And that does take some of their people's time, and you all have been through some of this. I mean, it takes time to do the interface and test. But we're happy to receive the data from them because it does make the system more valuable, we think. All right, so I went and pulled out of the EMR view because the screen res is dropping down pretty low here. This is the same patient, Heather, one partner. I pulled her up in the web view, so you can get to this without, so the administrators like this view better because they don't always work in the EMR. Same information, Heather, one partner. I went off the main tab and went down a little bit. Everybody know HCC scores and the value they bring in the model, you know, setting the budget, multiplier times the amount of money in the pot for that patient. So one thing that we've done, all your patients will have this if we've got information on them, is this right here is the first tab the doctors normally see. So you can actually see on this patient, hey, here's my risk score versus what the community risk score brings. So we take all the data from all the different locations on that patient, calculate a risk score, and then we take it from your EMR, the one you're in right now, and calculate a risk score. If there is a delta, that's usually a problem. That means that there's something being diagnosed somewhere else that you don't know about. CMS, believe it or not, their payers, managed care, Blue Cross, and all those guys, they have a way to actually push those on the back end to say, oh, here's all the diagnosis codes related to this patient or all these patients that were really in the chart, but they just didn't click the button to put them on a claim, right? And they push them in. Well, CMS is cutting that out. They're not going to let the payers do that anymore. So if the diagnosis code doesn't hit the claim, you're not going to get credit for it, right, is what CMS is doing. They're saying, no, the doctors have to do this, not managed care. So that's coming. That is a change that's coming. So this right here is literally the list for the doctor. You know, you don't have to go through the list and churn through it. We try to make it easy for you of the last year it was done, what it was, and you get to kind of go through and you've got a quick list for all that patient of all the diagnosis codes that they've had now in your clinic or somewhere else that need to be reassessed on that patient. We know this is kind of an annoying thing, but this is CMS's rule that you have to reassess these every year because diagnosis codes and risk levels have a tendency to drop off after two to 3 years. You know, legs grow back and all that stuff, which is not true, but that's their logic. Saves them money in the long term. So we have that. There's also the ability to look at the calculation. Anybody like math, statistics, and all that stuff? Well, there's all the math behind it of how the HCC score is built up, so you can look and understand that. There is a lot of value in that, but it's, you know, I don't know anybody that has time to look at it on every patient. Stratification, that's the level 1, level 2, level 3. I'm going to kind of move through some of these because I wanted to get into the other pieces. But that right there is all the stuff that builds up to make this patient a level 1, level 2, or level 3. You're really worried about those level 3s. This is what you're really focused on. And then obviously if you drop down, you see more about what's going on. Encounters, that's going to be where the patient has been in the last 24 months. And this, let's see where it goes here. This is going to bring back, right now, it's going to bring back every visit they've had with really anybody in the past 24 months. But when it populates, it'll also, you can filter to where it's just inpatient or emergency room stuff. That's the high value stuff. You know, if patients go in there a lot. So here comes some of it back. So let's filter that down. As you can see, inpatient encounters and all those, and as we get more hospitals connected, you'll start to see this. LACE score, anybody familiar with LACE score? So that's your likelihood of readmitting, the patient's likelihood of readmitting back in. Red's bad, yellow's not as bad, and green's okay, they broke a bone or something, but they're a kid and they more than likely won't go back in. Once it goes red, it rarely turns back, what we've noticed. What's really interesting is when you see a level 1 that's red, they've got some behavior that's an issue. Usually there's a psychology issue that's going on there because overall they're not unhealthy. They just go to the hospital for a lot of stuff. And those are things that we can actually chase and see, and I'll show you those in a minute. That's also eye-opening to physicians that don't know that. They'll see patients and they're like, well, I had no idea you were consuming this much resources. Those are what we call high utilizers. No reason to be in the hospital, great reason for an extensivist clinic or something like that. Treat them outside the hospital, you're going to save all that money. But the hospital doesn't like that. They want all that money. They would prefer that. Measures. Who likes quality measures? Do they help you practice better medicine? I didn't think so. They're there because, well, I'm not a doctor. That's not my job to tell you why they're there. But we have to calculate them. We have to score them. We have to do all that stuff. And you get judged on them, right? And the quality has to be top tier because we don't want to be lesser quality. So within this view, doctor's got the patient at the point of care. They click over on this measure tab, and bam, I've got some measures I've got to do. So right now, I don't think I'm going to overwhelm you. There's 2 for 2019 for this patient that the doctor needs to worry about. The goal for this is, doctor, this is the only, doctor, nurse, whatever, you know, these are the things that you need to do on this patient, right? We calculate these based off of all the community data. We also have the ability to, your data and the community data that's coming into the HIA, so we're trying our best to calculate them all the time. And we can build really neat rules. We can build really basic rules. The government ones are always they're never fun for us, but we have to build them anyway. 66-year-old female, they don't have hypertension. In controlling high blood pressure, you're supposed to do that, right? So we've detected that doesn't there. So either the doctor can, one, do a blood pressure. If it's within range, they type in their EMR, it comes across, except for McCook Clinic, it doesn't come across. That's the only one. Actually, you had 7,500 come across. They're just not showing up here right now. So we're going to fix that. I've checked that today. But the goal is you do your normal workflow, you get credit for this the next day. Right? In some scenarios you can't. So we built in some cool stuff here to where you can actually do an override. And what that is, the doctor could click on this. I'm sure the doctors are going to do this, not really, but care managers and stuff like that, when they're chasing quality measures, they might. But they can type in a few things, and I'm just going to check my email here real quick. No, I'm kidding. Let's see if this works. So we put a QR code on there. What you can't see on my phone right now is it's actually brought up an app that's tied to this web page. We'll see how this works, because you are going to complete a quality measure today. We'll see if this uploads here in a minute. But it's really trying to figure out how do we start taking technology and enable it for case managers, care coordinators, anybody that's doing quality measure completion and everything. And it says successful. Look. All right, so the image showed up there, and it tied the sessions together. So now there's a picture tied to all that stuff. And I can type in the systolic and diastolic. This patient's going to be really out of control. And we'll do that. And then I can save this. I've got, see, and we're smart because we check to see if those are right, and it doesn't like that blood pressure. I don't know if it's going to let me do that. Yeah, so it's not going to let me do that one. But anyway, that'll complete the quality measure out, and it'll be part of your auditing and reporting process. So that's how the ACO kind of goes in. At the end of the year, if you don't have that data, there's going to be people running around trying to finish those quality measures, right? So that's why we try to calculate them based off the data and the interfaces you all give us. We give you the ability to also upload a file in case you all store it. Say you have a scan system somewhere, or you check some weird box that we don't know about that doesn't come across to the HIE or something. We give you the ability to say, oh, yeah, we'll have our local vendor just build that file and upload it, so we can fill those in as well. And then take claims information in as well. Maps and alerts, maps is really where does this patient live, so it's kind of creepy to some people, but if I move that around, it'll actually show you an address of one of our buildings in Kingsport. It actually does Street View too, which is really freaky, because people think Big Brother's watching them, but this is all publicly, available stuff. But one use case that's been very valuable is home health and those type of things. When they're going in, they kind of know what they're going into, and that's a valuable thing. So now, that'll continue to run. One thing I didn't show you is we actually have a little case management thing in there as well. So up in the right-hand corner, there's these cool little icons. One thing for anybody ever have to track controlled substances for patients? Check a state database, right? So in Virginia, Tennessee thinks they're smarter, so they want to do it different. But in Virginia, we're connected directly to the controlled substance database. One click from this application, you're in the patient's controlled substance chart. You get credit for checking. You get to see it's the same reports come back, but you get all that information with one click, right? And that's, if you all want to look at that in Nebraska, we'll be happy to do that. It's the same vendor. It's called Aparis is the vendor. But we just have to have the conversation with the state of Nebraska to allow that. But we can do that. There's a button that does that, and there's also a button that's for case management notes or horizontal patient record, whatever you want to call it. And you can click on that and you can type in things about, hey, I called Susie today and Susie's not feeling well, and anybody else in the system can see those comments. It's kind of like a Facebook wall where you can, post comments and they just kind of stack up over time. Kind of a valuable thing. Now, this right here, is anybody familiar with these screens? Anybody started looking in patient or provider insights in any of Samantha's meetings? Anybody work in Samantha's meetings that she has once a week, once every two? Okay. You don't have to talk bad about Samantha. No, I'm kidding. Samantha's fantastic. This right here is provider insights. This is the part where the doctor said thumbs up, the administrator said thumbs down. So this is what we built to make the administrators happy and really to do kind of population health and value-based management. So within our algorithm, we assign patients to providers, and we know they've been to those clinics, and we use all that. What you're seeing right here is literally just for a clinic, and if any of you all want to look at your clinic, come up to me afterwards and we can pull it up and look at it. Am I doing it on time? Okay. But first thing we do is we break down the population by age range, and then by male, female, and then by strat, level 1, level 2, level 3, right? So for this clinic, they've got a lot of patients, and they've got some 75 plus, and you can't really see the gradient change in some of the reds and the blues, but you got level 3s and level 3 males. They're all the way at the top of this, very small percentages. It's about 5% of the population that they've got. That's where all the money's spent. All this stuff, and then it's based down by age range. You can click on any one of these and it'll take you to a list of all those patients. So if I click right here, right now, I'm not going to do that, but we've got 1,414 level 3 female patients. Right. So if I had something where I wanted to do some program, I can click on that list and I can get down to that list of those patients. So everything here is designed to run action, right? This right here is not designed just for you to look at and say, oh, those are cool numbers, we like those. There's always got to be an operational reason to use any of this information. And these are on your attributed patients. You know, you also have active patients. You know, those are patients you've seen in 24 months, but maybe they're going somewhere else more than they're coming to you, right? So you can also see those patients to see what's going on there on the active. And then up here at the top, we really have just kind of a breakdown. Very interesting fact is this right here, average age of level 3s in Tennessee is 71. Would you all take a guess on what the average age of your level 3s is in Nebraska?
85.
More like 74, but 3 or 4 years, they are aging better than we do in Tennessee. But in Tennessee, we have what we call the GBI. Anybody ever heard of the GBI? It's called the Gravy Biscuit Index that we have in Tennessee. And there was a thing with USA Today 5 years ago. I don't remember when it was, and they said, oh, the top unhealthiest places in the country, and Tri-Cities, Tennessee was actually like number 3 on that list. Something really ridiculously high. That was USA Today. That same day in our local paper, Krispy Kreme and Popeye's Chicken opened up. So we've got that going for us, right? We've got plenty of great food. But no, we definitely have a problem. People don't live as long down there. You know, we've got a problem. Yeah. So within this tool, you can break it down by provider, by payer as well. We also have another feature coming to where we can say, here's a list of patients that go in a certain list, and that's all that runs through there. That's going to be really helpful for the ACO side of things, because our algorithm tries to take your insurance and figure out what buckets you go in, but people type insurances in different in their systems, so it's not always perfect, but it's pretty close. So now we get down into, all I did was filter down to a smaller population set. This is a zip code breakout. This might be useful to you all when you're looking about what zip codes you're serving more often and where your level 1s, level 2s, level 3s exist as well. I don't know if you all have like an epicenter of your level 3 village. I doubt it. And they got their own zip code, but it'd be all red there. If you do, that'd be interesting to learn more about. Encounter trends. So this one's normally pretty interesting because these are all the patients that belong to you. And this is the number of visits they generate in the community each month, right? And the type of visit they generate. So, you know, ambulatory visits, thumbs up. That's money in your pocket. That's that prepayment, right? Pediatrics, thumbs up. You know, those are good things. We got to do those. Primary care, same as ambulatory, thumbs up. But surgical, maybe it's scheduled surgery. Palliative care, that's okay thing. We don't want to look at that. Oncology, we're not going to do much about it. Psychiatric, oh, but wait, look, all those. So for your population, as we connect these entities, and this is, Samantha has all this, is what she runs on. For the Medicare population, those patients are generating 1,000 encounters a month, you know, throughout the year in the community on inpatient and emergency room services. And I don't remember what the attribution was, what the number is at the top, to give you the per 1,000 rate. So this is on 10,000 patients. So they're generating 1,000 encounters a month. Those are probably level 3 patients consuming most of those, and they're doing them inpatient, right? That's what you want to stop. How do you get in front of that and stop that from happening? Because that's the money that you're going to be able to save and put back in your value-based pot to pay your physician more money, right? And every time they stop one of those, that's $10,000. And then if you're actually giving them like $20 to see the patient, that's a pretty valuable thing. That's a good return, because the best money is the money you really don't have to work that hard for. It's just the patient gym memberships. Best money in the world. If you can get people paying for a gym but never using it, it's easy, right? So that's what you want. You want more of that type of stuff. But you really want to trace those level 3 patients, right? So this is another one of the tabs, and you all will work through these throughout the year. But as this comes up, this is the acute tab, right? So let's connect up McCook Hospital. Let's connect. If anybody has a hospital in the region that they do a ton of business with, let's get a phone call going. Let's figure out how to get them connected. Yes, the hospital can subscribe to the services, so when your patient shows up in the emergency room, they see everything you did. We'll be happy to sell them access to that, right? I mean, that's part of it. But they need that information too. For the Medicare population, it's at 143 added together, 143, and this is discharges, you can't see it, but discharges in the past 30 days. This is that, I'm going to do a transition to care. I'm going to bill, what's that pay right now? Anybody know? $200, what's a transition to care pay? $203. $73, so not very much here, but Tennessee's paying us more, evidently. I don't know. Multiply that. That right there is, yes, you're going for fee for value, but the more of those you do, then they want you to do those. That right there just boosts your fee for service, your prospective payment. That'll fill up your empty schedules, right? If you have empty schedules. If not, it'll allow you to bring in more partners. But that helps you generate that revenue and actually schedule those patients and do that transition to care. And then you're going to figure out, why are you going to the hospital? How do we keep you from doing that in the future, right? Because now it's already happened, but they expect stuff to happen after that. So you click on, if I click on that, it brings up a whole list of every patient. You can see who they're attributed to. You'll see their LACE score. You'll see all that information right there. And your case manager, normally case managers and care coordinators are working these lists, and they'll prime and put them on the schedule, and you'll show up in your office 2 days later, 3 days later, 5 days later, something like that. And usually, well, you'll have the agent, so you'll know why they were in the hospital, but sometimes they'll prep you with some workup stuff, or maybe they'll go in and look at all the diagnosis codes that have not been done, and they'll load those up for you to assess, right? That's what that tool's there for. You can also drill into level 1, level 2, level 3 in your readmission rate. Level 3s usually have a high risk of readmission. Now, you might notice a trend about level 3s. Those are the ones that we're only focusing on 5% of the population normally to make a big difference in healthcare. So that's why it's worth spending that time on those. And the only way you keep your attribution is if an MD or a DO sees that patient. So if they come in and see a mid-level or nurse practitioner, you can lose that attribution out of your clinic. And so you want that attribution to come to you. It is a good thing. Attribution is a good thing. Here it is by day as well, so you can go back and say, give me all the ones yesterday that discharged. HCC, yeah, this is a good one. So HCC, this fills your bucket of money that you're going to be counted on and multiplied by. So what I've got, I've got 15 more minutes, I think. Yep. Okay. So this is a fantastically complicated graph, but we have level 1s, level 2s, level 3s, and then we have the number of people that fall in those populations. So within the Medicare population, we only have a little over 3,000 level 1 patients, 6,000-ish level 2 patients, and then look at that level 3. There's under 2,000 of those, right? Those are the sickest of the sick. Those are the ones that are. Now look at these bars are the HCC scores, right? Over all that whole population, right? Average HCC score. Level 1 patients, we're saying a 1.0 is kind of a normal Medicare patient, right? That's an average healthy Medicare patient. They don't have very high HCC scores, right? So there's not a lot of chronic conditions, so they're very low. But we'll go over here and look at level 3s, right? So you got 4 bars, and they are different colors on my screen, but up here they're not. So this is a blue, this is a purple, and these are different shades of purple and different shades of blue. Current year, last year, right? Community versus local. So this, if you took every code on the community and did it on your Medicare patient population, you would have an average HCC score of about a 1.75, right? And so that's take 10,000 times 1.75, and you're going to get what, $1,750, something like that, or $1,750, right? So that's how much more expensive those patients are to care for, right? And then that's your delta, and you've got opportunity to make money. Well, it's the beginning of a new year, right? All the HCCs go, I mean, all their chronic conditions went away, according to CMS. Everybody's healthy on January 1. So this is your kind of indicator of you have to get back up. This is your top potential on your entire population. So a coding exercise, anybody ever go through coding opportunities, trying to find patients to recode and up, get the coding up higher and drop codes and all that stuff? Anybody ever do those exercises? Get ready, because you'll probably start wanting to do those, because that's how the money's in the pot for you all to distribute out to physicians. But I click on one of these buttons, I literally get a list of every patient. I can sort it by how many HCCs or the total point value of that, and I can find a patient that has a 0 because they've not been into the office this year, and they're really a 9.0, a 9 times multiplier. There'll be a $90,000 spend allowed on that patient here. That's a very valuable part. It's not a very fun part of healthcare, but this is how insurance companies think, right? And now in your EMR, in your practice, you have the ability to see how insurance companies categorize patients. The whole name of the game is doctors, part of it's learning how to take risk. Insurance companies manage risk. They're dumping that risk on you. Is it really risky if you know everything? Not usually. So this gives you the ability to kind of see the risk that's coming. You can identify where most of the spend is. Level 3 patients. Also, this is a helpful thing, because not everybody always remembers all this stuff and has all the training programs. Everything does have a question mark, which goes to a YouTube video that tells you why this tab's important. So you can self-train and that type of stuff. So, and that's Anthony's voice. He's not here today. Outreach I can't click on, but that's a great tab. Samantha and them use that tab a lot, and what that is that's a list of all the patients that are going to age into Medicare in the next 3 months. We're getting ready to have a birthday, turn 65. They're probably super happy, right? So you can call them and say, welcome to Medicare, and if they're going to go in. And when you do that, you'll schedule the welcome to Medicare visit, and you'll get them in, and they're going to be super happy, and they're going to lose weight, and they're going to do all those things. But they help your attribution, right? And they also are usually healthier patients because they're coming in younger. I say usually. It's not always there. It's level 3s in that bucket as well. But you'll know that because you know what the patient is already. We've already calculated that. But your attribution, the better, you want healthy patients to offset the unhealthy patients. And you need a good balance of those, right? Within this room, does everybody have the healthiest patients or the unhealthiest? Don't know. You probably got a mix of all of it. But you probably know a clinic somewhere who's not really doesn't understand anything about managed care, and they don't know anything about where their patients are going. Does anybody know maybe some partner down the road or something like that? You still want them in your ACO. You still want to do business with them because your population's well managed. Theirs is not well managed. You can make a difference in their population, and you all can bring some of that money into your ACO, and you can share it among everybody. You can divert them and run them and have them doing stuff in your diagnostic centers versus having them going to the hospitals. It's all about working together as physicians. I'm almost done. Maps, that is going to be, well, the next part of outreach, what is it? It's level 3 is not seen in, level 3 is not seen in 90 days. Right? So how do you keep a patient out of the hospital that's got all these chronic issues? You just talk to them more often. Let them know they can come to you. Build that relationship with them. Physicians interacting with their patients, they get to where they're like, oh, I'll call you rather than show up in the hospital. Or, maybe you'll get a little bit ahead of the curve and you'll say, oh, you're not feeling good today. Okay, let me get you in. It's doing some of that stuff. But getting them in the habit of interacting with you so they don't show up to the emergency room. Tertiary or rural hospitals, little, basically small clinics that are just feeders into the big hospitals, what those normally are. Hospitals love those, and they believe me, the government pays for almost all that. The hospitals bear almost none of that cost. We as taxpayers bear most of that cost. They feed in there. The first thing they're going to do is say, the doctors don't do this, but the administrators have already tagged a price on top of that patient's head, and they're going to send them to the big central hub, and they're going to work them up. They're going to do as many MRIs as they can. They're going to do as much as they can. They're going to really run the fee schedule on that patient through the roof, and then they're going to send them home, and they're going to go way back out there where nobody's going to take care of them, is what normally happens. Don't want it to happen. You want to take care of them, and you want to basically see them every 3 months. And if you see them every 3, probably need to see them more than that, but you don't see so many patients. See those level 3s every 3 months. It helps your scheduling, right? You start booking those empty spots, and the patient feels they're building that relationship with you, and then you hopefully avoid that admission, right? You can't really avoid the car wrecks, and you can't avoid the broken arms. You know, we can't predict the future that way, but we can definitely look at the behavioral pattern of a patient and start to understand that they're more likely going to go in. So that's what our level 3s not seen in 90 days is. And that's kind of part of how the ACO manages that, and how you actually reduce that spend is you put those habits in place and you start filling your schedule with them. Measures. Everybody loves measures, right? Let me see if I can't find something at least cool to show you. So we calculate a lot of measures on patients, and that's basically a bunch of software that, a bunch of stuff my team writes. And we do all the ones for the ACO and for HEDIS and all that, because we know how much value they bring to you guys. Not really, but we also get to play occasionally and do some of these neat things. So patients with a LACE score, high LACE score, right, level 3, you know, that are level 3s. Let me see if I can look at those that are Medicare. So this is kind of some of this neat stuff that you can start doing with this data. So right now, these patients right here are all my level 3s. They're Medicare, so there's like almost 40 of them. And then there's a stratification one down here, and these are all level 3s, right? So what if I want to see the ones that have both those, level 3s that are going to readmit in the next 30 days? This is called a Venn matrix. If they've got a check in both, they're more than likely going to do both those things. And you as a doctor could click on the icon, click on this, and filter your population and actually see. And if you click on any one of those names, you're going to go to a patient chart. They're going to be a level 3, and they're going to have a high LACE score. That means they're going to go back in the hospital. Probably worth prioritizing at the top of the list to call, because you don't want them to go to the hospital. So let's go down and say, all right, what else can we do here? Get your hospital connected, right? So these two measures, let's see if we get anybody to pop in the list. If we do, then it's East Tennessee. I'll be surprised if we don't get somebody to pop in this list on all these. Oh, guess what? 2 of them, right? Level 3s, somewhere, level 3s. Going to go back into the hospital, right? 5C, they've been in the hospital 10 times already this year. 7C, they've been in the emergency room 10 times or more already too. So now, these are 2 patients that are totally out of control, and you found them with a few clicks, right? So now somebody can call them and do something. Or they can, or they don't have to. But anyway, I hate it when data is what slows people down. So we built all this trying to I was asking questions, and I'd ask my team, and I'd be like, well, I see him in here, but I'm having to wait. It's taking me too long to find him. I need it like this, right? So this right here, it's neat when you take this and you go, okay, give me my level 1s that are doing a bunch of this stuff. So why are level 1s going to the hospital a bunch, right? Either one, they don't have a doctor in PCP. Throw an opioid measure on top of that. We've got them. They usually always have that opioid check as well. They're chasing drugs, that type of thing, right? So this helps you kind of identify that population and work those. And this is just the Medicaid population. You know, usually when I see this, it is that psychiatric issue that's going on, that if you drill into those.
And the time frame, Wes, you're looking at this?
The time frame for these, so it's limiting, so the LACE, it's 30 days. They're going to readmit within 30 days, so that's going to be 30 days from now towards then. And then on the time frame for the for 5C and 7C, I think they've been, I think that one's they've been in 10 or more times in 12 months. In the past 12 months is what they've been in on those, right? And the cool thing is we develop these, everybody gets all the benefit of all the measures. And you can decide what you all want to see and what you all want to sort on and stuff like that. But we run the algorithms on the patient every night. So, yeah.
This is based on how recent the data.
So our feeds are usually real time. So like, I mean, The system's getting, so this screen updates we update the data set for this every night, but usually within 24 hours. There's no claims data feeding the system, none of that. This is all coming out of your EMRs, and usually it's within a minute, 5 minutes, 10 minutes, sometimes 24 hours, depending on, there's a few old EMRs that can't handle real time, but it's usually 24 hours. So the hospitals are usually real time. So we're working a day behind normally when we calculate all this stuff.
But that has to be calculated from in one partner.
We calculate that based off our data set. Yeah.
It's not in one partner.
Correct. If it's not in one partner, we don't know that the encounter happened or any of that stuff. Now, we continue to, this goes into those future slides about what are we developing in the future. We don't focus on cost data yet. Why don't we focus on cost data yet? Because there was a lot of value out of the clinical data. And there's a bunch of vendors that do a bunch of stuff with claims data already, right? So we said, well, they're doing a lot of that already. We're ready to solve this problem, not solve that one. But we're going to bring in the cost data, but we have to do it across all payers. And it's all centered around that patient, so we try to relate everything back to the patient. And when I say cost data, that means claims data, which means there will be encounters and certain things that we learn from that claims information that we could also learn through a clinical interface, but we're not interfaced with everybody in the country. Not yet. That's the promise in the future, right? Interoperability will get easier. We're ready for that too, because we spend a lot of money doing interfaces. But yeah, it's based off of the clinical interfaces we have.